let's go to the second talk, and then we will. I already have a question, but let's go first to the second talk that will be performed by Claire Francoz. Claire is an hepatologist and intensivist working in Beaujon Hospital. Richard just showed us that liver transplantation can save life of those cirrhotic patients, but we all know that some of those patients may be too sick to be transplanted, and that's the first thing. And the second thing is that some other cirrhotic patients are waiting at home for a graft. So this is an issue, and Claire will tell us how she thinks we can reconciliate individual and collective benefit in this context. Thank you, Claire.
Thank you very much, Manu. Thank you for your kind invitation, and good afternoon, everybody. Next, please. I have no disclosure. Next. So ACLF is now a recognized indication for liver transplantation, and you have on this slide several studies from different Western countries. As you can see, results are good, with 1 year survival ranging from 75 to 84%. Next. It's, however, important to keep in mind that these good results derive from uncontrolled studies that had included highly selected patients. And there is also a huge heterogeneity regarding the number and or the type of organ failures in all these series. Next. I would like to stress that there is ACLF and ACLF. Here on your left, a man, 70-year-old, serum bilirubin 30 micromole per liter, INR 1.6, under mechanical ventilation and RRT. And on your right, a man, 46-year-old, bilirubin 500, INR 3, creatinine about 200. Next. Both have ACLF grade 3. Next. But undoubtedly, I would prefer to transplant the man on the right side because he has clearly a better post-transplant prognosis than the other, who is at very high risk for death after liver transplantation. Next. In all Western countries, liver transplantation is limited by the scarcity of grafts. For instance, as you can see here in France, there is 1.6 candidates for only one graft. Next. Thus, we should balance between, in one side, individual benefit of liver transplantation, and in the other side, the collective benefits, meaning that candidates with a low probability of survival after transplantation should not be transplanted. Now, how to deal with that? Next. The issue is to look at the impact of each pre-transplant organ failure on post-transplant outcome. Here, the study with a very high number of ACLF patients showing post-liver transplant outcome, either under mechanical ventilation, the red line, either without, the blue line, at time of transplantation. As you can see, mechanical ventilation has a poor prognostic impact on survival. Next, under mechanical ventilation, 1 year survival is below 80%. The prognosis is especially poor in patients with ARDS, but the main limit in this study is that we don't know why patients receive mechanical ventilation. However, these results suggest that pulmonary failure may be a contraindication for a liver transplantation. Next. The limits of liver transplantation in ACLF remain not evidence-based, and here is a very important study of Emmanuel Weiss, our chair, using Delphi approach. 35 international experts have participated, and here are the main results. 71% of experts consider that pulmonary failure with a PF ratio below 150 is a contraindication for liver transplantation. Next. Regarding hemodynamic failure, a dosage of noradrenaline over 1 microgram per kilogram per minute is a contraindication for 73% of experts, and lactates over 9 for the half of the experts. Next. Now, what about other organ failures? Liver, coagulation, and brain. As you can see here on this large US study, these failures have no negative impact on post-transplant outcome, suggesting that there is no limit of severity that would contraindicate liver transplantation in these patients. Next. Next, please. Finally, beyond organ failures included in ACLF classification, firstly, age should be taken into account. And you can see here poor results in ACLF patients grade 3 over 60-year-old. Secondly, sarcopenia, but we still lack data and limit and frailty with a consensus suggesting that a frailty score over 7 is a contraindication for liver transplantation. Next. So here are my take-home messages. Liver transplantation in ACLF patients offers good results in selected patients. Severe respiratory failure, PF ratio below 150, and hemodynamic failure is at time of liver transplantation is a contraindication for liver transplantation. Liver transplantation in ACLF patient grade 3 over 60 years with severe comorbidities and malnutrition is questionable. Ongoing sepsis remain a key issue. An allocation system based on MEL score is not appropriate in patients with ACLF. Thank you very much.
Thank you very much, Claire. I have now two questions for, I think it's more or less for all of you, and it will be a matter of debate, I think. The first question is, should we prioritize those patients, those critically ill patients, for liver transplantation? Maybe for Claire and Richard?
Yes, it's a very important point, but I think that we don't have any response now. Maybe Thierry will talk about that in his talk. Prioritization of such patients is always debated and difficult because you have always to balance between the elective list and other patients. So we have to find a balance, and it's very difficult.
Okay, so let's wait for Thierry talk. And my second one is, you said that MELD is not appropriate. Okay, meaning that, and it makes the link with the talk of Richard, meaning that finally this is the importance of the ACLF definition and the ACLF syndrome. So what should we use? Should we use should we stop using MELD and use ACLF grade? Do we need something else? Should we optimize this specifically for liver transplantation? What is your answer?
Yes, MELD is now an old score, and I think that it was very useful during the past in patients with, for instance, HCV cirrhosis, and we know that these patients, when they are severe, had high serum bilirubin and low coagulation. Now, for instance, in France, we have looked at the list at candidates for liver transplantation, and only 30% of them have high MEL score, and the others have low MEL score with severe disease. So it's exactly the same for ACLF, and in our experience, maybe 50 to 60% of patients with ACLF grade 3 have low MEL score, or less than 30 or 35 MEL score considered as high MEL score. So clearly we have to move to another score.
Thanks a lot for your answer.